Well, I'll start talking a little bit about presentation. So what I want to share with you today is about a pilot intervention. Oh, there we go. That VMIA has developed in partnership with Behaviour Works Australia, but also with the sector. And this pilot intervention aimed to address some of the challenges related to misdiagnosis in emergency department. But before I start, I just would like to talk a little bit about VMIA for some of you that may not be familiar with it. VMIA is the Insurer and Risk Management Advisor risk advisor for the state of Victoria. We insure over 4,000 clients, and it's part of our service provision. It's based on our mandate to protect the state's assets and liabilities, but also to support the sector to manage risks. Now, if we zoom into the health sector, VMIA insure 149 public hospitals. And as you can see, that comes with, 1.64 million emergency presentations, 1.5 million hospital admissions, and so on. So it's a very complex and busy environment. And although Victoria is one of the safest places, I think, to receive health care, and coming from Brazil, I can tell you that's absolutely true, we do have around, VMIA manages around 250 claims every year. And these 250 claims, they vary from their severity, from the impact on staff, for the impact on families, the cost to state, and so on. And we can tell you that the majority of these claims, unfortunately, are related to events that could have been prevented. In recent years, since I got the role as head of Insights, one of the main priorities for our team was to really be able to look at our claims data. We are in a very a great position to have a holistic view of what happened across the sector in terms of claims. So it was very important for our team that we're able to crunch the data and understand the contributing factors and some of the critical causes that are leading to those claims. When you look at our portfolio, I can tell you the obstetrics and emergency, they are by far the majority of frequency. They represent the larger frequency and the cost of claims. But what we have noticed in recent years is that although the claims increase over time, we've noticed that obstetrics, that increase has been less than expected. And we believe that's being related to the fact that there's a lot of work that has been done around the sector in terms of risk mitigation strategies around obstetrics, some of which VMIA is actually funded, like prompt and the fetal surveillance. But around emergency, we haven't seen the same rate of improvement. So we're very keen to understand what was happening in that area. So when we look at emergency claims, and I will quote some numbers because after all, so of the claims that we have coded so far, we can tell you that of the 1,383 claims that we've coded, 236 are emergency-related claims, which is around 70% of the total incidents. Of these 183, 78% of the emergency-related claims had missed, delayed, or failed diagnosis identified, or diagnosis as an identified risk factor. And then out of those, 36% of those related claims had differential diagnosis as a critical risk factor, which is that challenge of that initial diagnosis. And I'm sure that's not a surprise for you, but at the end of the day, I think it's very powerful to see how the data comes across. Now, claims is just a small piece of the puzzle, yeah? It tells you about some of the issues that some of the health services may be facing, but that's just, we need to look outside VM. If we're wanting to help the sector to address some of these issues, we need to look outside VMIA walls. And that's why we decided to run a research and innovation program. It's a program that we have in partnership with Behaviour Works Australia. They are experts in behavioral science. We're looking at 6 healthcare challenges to address. And one of the first things that we wanted to look at is misdiagnosis. So it's about looking at the claims, what we're seeing in relation to claims in Victoria, in emergency department, around misdiagnosis, but what's happening elsewhere, what are some of the evidence and some of the literature that talks about some of the challenges elsewhere and how we best way to address them. So the aim of the pilot is called the Rapid Diagnosis Discussion. And the aim is to ascertain the feasibility, acceptability, and effectiveness of the rapid diagnosis discussion as a tool to reduce misdiagnosis of patients presenting to the emergency department with abdominal pain. So just to give you a bit of a background, of course, you know, diagnosis involves a complex process of gathering, synthesizing information, and that is magnified by the emergency department. So that's no surprise that we have so many issues around misdiagnosis. And there is a significant focus that's being applied to understand the role of cognitive bias in diagnosed decision-making. And we've chosen abdominal pain because we had, in Victoria through 16 and 17, there was over 79,000 presentations that were diagnosed as abdominal and pelvic pain, providing sufficient volume for us to do this study. Now, one of the things about developing an intervention such as this is that, as I said, we use the claims information, we use the research and the research experts around behavioral sciences, but also we use health sector experts to help us develop the intervention. So there were a number of workshops and a lot of research that was undertaken for us to come up with the project that I'm about to share with you. So the pilot was around providing a second review or time to reflect on diagnosed decision. And that type of approach has been shown to be effective in reducing diagnostic error. This is particularly true when reviewing junior doctors' cases, where senior clinicians review cases, they change course of treatment 30 to 40% of the time. This independent review will assist us in combating some of the cognitive bias such as anchoring, using initial piece of information in subsequent decisions. So what the project entailed was a number of questions. So if a patient was presented to the emergency department and they fill the eligibility criteria, which will be signs of abdominal or pelvic pain, then the clinician would be provided with these questions, and that would give an opportunity for you to challenge that initial diagnosis. Unfortunately, I have to say that I was hoping that by today I would have the final results of the trial, and all I have to present to you today is the preliminary results. And what we're seeing is that there were 30 to 40 clinicians involved in the trial, and there were 175 patients. And this trial we run at Eastern Health, Box Hill Emergency Department, and we have Maroondah and Anglers as the control groups to give us an opportunity to really do a robust evaluation in relation to the outcomes of the pilot. As you can see, 70% of the clinicians found having a second clinician's working diagnosis to be most helpful, and 41% found the most useful aspect, found that it was a simple mechanism to help them challenge that initial diagnosis. Now, the proper evaluation of the program will involve things like emergency department length of stay, return to emergency department within 48 hours, time to bed request, discharge destination, and change in diagnosis after completing the form. So all this information will be available for us to have a feel as to how successful and effective using that type of tool might be to help in the diagnosis process in an emergency setting. Now, and here we have some of the comments that we got from the clinicians that participated in the trial as well, which is, I know it's still early days, and we can't put our, hand at heart and say this is a good tool and should be used by emergency departments. But having said that, I think we feel pretty optimistic because of the way the pilot has been developed with the participation of a number of clinicians and experts. I think we're probably going to have a good result in relation to being able to improve outcomes. But the next steps from here will be to collate all the data that we use as part of the pilot, and of course the the findings will be available and be published, and we'll be working closely, depending on the results, we'll be working closely with the sector, the Department of Health and Human Services and Safer Care Victoria, to perhaps investigate the possibility of sharing that or funding that pilot and that program to another health service, to other health services in Victoria. I think because we have done the pilot just at one site, at Eastern Health, probably for a statewide rollout we would need to run at a larger scale and probably include metro and regional. But I think it's very exciting to think that we're working closely with the sector and researchers to look at ways to help prevent harm in Victoria. And I would like to share with you as well that the Research and Innovation Program, which is going to be running for 3 years, it's already have interventions around board governance. We also work on an intervention around patient's voice, and the next 3 topics will be decided in the next few months. So I hope I'll see some of you participating in some of those stakeholder groups, and yeah, that's it. Thank you very much.